process really hasn't changed that much over the years. A patient comes in, they have some tests or they have some procedures, and those are billed accordingly. Now, what has changed as over time, we've seen an increasing amount of not only data because we're capturing it, but also the number of visits have increased. And part of the reason behind that, and probably the full reason behind that, is the fact that our population is aging. So this is due to the fact that the baby boomers are now getting older and utilizing healthcare resources much more than they ever did before. As I mentioned before, healthcare is a business, and most of the people that are going into healthcare are older, and a lot of them have Medicare and Medicaid. So government is the primary customer, if you will, of the hospital system as far as paying for these services. And of course, over time, that's just going to it's going to increase more and more. Also, because healthcare, like I said, is a business, then they're still looking at these charges. It's very complex, and they're still looking for value. But because of the legislation that's being passed and has been passed, we're looking much more at outcomes-related information and being able to pull that out of the revenue cycle systems. Of course, this is predicated on information, and that's where the HIM or the electronic medical record comes in. Because, of course, clinicians are increasingly asked to document more and more the procedures and the situation of the patient, medications, tests, what have you. Then that data is then coded and then sent to either the insurance company or to the federal government or state government to be reimbursed. What you also see is that insurance companies will frequently ask for or require certain documentation, and CMS goes, you know what, that's really a good idea, and they jump on board. More frequently, you'll see that CMS starts requiring things, and that the insurance companies say, hey, we think that's a good idea too, and they end up copying each other, so that there's increased pressure on the healthcare facilities and ultimately on the clinicians that provide the services to the patients to make sure that they're documenting everything so that the billing can be done. The uninsured population presents an additional problem in that hospitals still have to and are required to provide the same levels of care for the procedures and for the patients and who receive the procedures that they do for health insurance as well as for CMS and the state government, but they're not getting paid for that. But they still are required to stay at that same standard that they are for procedures and patients that they are getting reimbursed for. So somehow the hospital actually has to find value in a lot of what they're doing to try to provide the care that they're required to provide. The advent of ICD-10 and the transition to that has helped to make things even more intricate, but also to help and allow for more accurate billing. Back in the day, we used to go into the supply room and take out a Foley catheter kit, for example, and there would be a pink sticker associated with that. We would then go into the patient's room, and we would actually stick that sticker on that patient's sheet, and at the end of the day, we would round up those sheets and send them down to be charged against the charge master so that the hospital could be reimbursed for those things. So especially in a paper-based world, there was no documentation other than writing that the procedure had actually been performed. However, there was, a charge for an item that could then be traced back to that paper. Well, now, with electronic medical records and the increased documentation requirement with barcode scanners, we're able to track and trace these things much more accurately, because a hospital, as mentioned before, is a business, and it must be able to track its costs and be able to charge for services that are provided. So, we don't really think about it as clinicians walking around providing patient care. We're not in the business to be in business. We're in the business of patient care. That's why we became nurses and doctors and clinicians and therapists is because we wanted to help people. But we're really not thinking about the impact of that from a financial standpoint, because that's not our focus. But from a management perspective, especially on the unit or in the department level, we're definitely tracking those expenses because we're accountable for those to the organization, because the organization ultimately must make a profit. Of course, with that ICD-10 and with the increased work involved around capturing things like this, you'll see things like RHIAs and RHITs really in hot demand, because they are so important in maintaining a healthy revenue cycle for a facility. Again, we as clinicians are not really thinking about that. And although it might take me 3 or 4 catheter kits to actually straight cath somebody, I'm only charging them for 1. Well, technically that's considered to be, I don't know if it'd be theft or shrinkage or how you would look at it from a business perspective, but ultimately it would cost money. And we need to make sure that we're providing the level of service that we are, and of course the quality of care that we are, but we're also capturing the charges so that they can be passed on to whoever's paying for that.